Assalamualaikum and good morning to everyone. So I would like to thank the Dr. Widat and also organizer for having me here. So I will be presenting on the benefit of perioperative antivegf for diabetic vitrectomy eyes. Now, when we talk about perioperative injection, we'll be dealing with injection of antivegf either before surgery or immediately after surgery. So this is going to be the overview of the presentation. I'll be sharing on how antivegf assist diabetic vitrectomy cases, which is the best antivegf, when is the best timing to inject, what are the precautions that we should take, and when not to use the antivegf for the vitrectomy eyes. Lastly, I will briefly highlight on the issue of the use of antivegf immediately after surgery. Now, these are the common indications for diabetic vitrectomy, which is either due to non-resolving bleeding in the vitreous cavity or recurrent vitreous hemorrhage, due to retinal detachment, either pure traction or combined cases. We also subject patients for surgery if they have abnormal vitreoretinal adhesion, which is the vitreomacular traction or the epiretinal membrane. Now, however, not all cases require antivegf before surgery. So among the common indication which warrants an antivegf is patients with vitreous hemorrhage, retinal detachment, as well as those with pre-existing rubiosis iridis. So in other words, those with pure vitreomacular traction or adhesion probably do not require antivegf before surgery. Now, let's look into the issues of injecting antivegf before the vitrectomy. Now, these are the common scenarios we see during vitrectomy in diabetic eyes. So, we either do vitreous hemorrhage cases or traction retinal detachment cases. For vitreous hemorrhage cases, we can either do a case with fresh bleeding in the eye with or without prior complete laser, or we might do a case which has a mix of fresh and old blood. And sometimes we do for non-resolving vitreous hemorrhage cases, whereby all the red blood cell has denatured, and what we see during surgery is merely all the white opacities filling up the vitreous cavity with or without the presence of retinal detachment. Now, who would benefit from the antivegf injection is merely those who have a fresh bleeding inside the eye, either a pure fresh bleeding or actually a mixture of old and new blood. For those with chronic vitreous hemorrhage, sometimes I don't really inject antivegf for these cases because obviously, indirectly it tells you there's no active bleeding inside the eye unless there's a presence of combined vitreous hemorrhage and retinal detachment that would need some peeling. Now, if you have a patient with traction retinal detachment, again, this is just to share how do we do the segmentation. So when a patient has a traction retinal detachment, they have this broad plug on the retina with multiple foci of vitreoretinal adhesion and a shallow area of retinal detachment along the fibrosis. But when we come to a complex cases, usually what happens is a complex means there's a combined TRD, RRD. The retina is usually more highly elevated, and at the same time they have this multiple foci of vitreoretinal adhesion, strong vitreoretinal adhesion, which makes the inducing of PVD a little bit difficult. Now, in summary, what are the issues pertaining to these diabetic eyes? They usually do not have a complete PVD, especially after they have received, a pan-retinal photocoagulation. What happened during the induction, we can again induce tear because they usually have a very much strong vitreoretinal adhesion. For combined TRD, RRD, sometimes the retina can be very quite stiff. Again, we may induce a tear, and it is not uncommon for us to not to be able to find the tear. It does not follow the Linkoff's rule. So what happens is usually the tear will be hidden underneath the fibrosis, or it might be hidden within the stiff retina. Now, apart from the PVD and also the complexity of the retina, they also have these issues with the poor perfusion of the optic nerve as well as the retina. Again, on top of that, they will have these abnormal new vessels at the disc and new vessel as well. So how do we secure bleeding if it happens intraoperatively? Now, this is just an example how what we see during surgery. If let's say there's so much of bleeding, we hardly can see the tissues that we need to deal with. So what happened as a reflex, sometimes we increase the bottle height to almost 60 millimeter mercury. In a normal situation, we operated within the bottle height of 20 to 30. Some people might bring it a bit lower because of the perfusion issues in diabetic eyes. But when this bleeding happened, we just increased the bottle height to about 60. So again, you can imagine if you repeatedly increase the bottle height during surgery, it will cause a detrimental effect on the so-called pre-existing poor perfusion of the eye. So we try to avoid that as much as we can. Now, another way dealing with this bleeding is by using the heavy liquid as a temporary tamponade. But you have to remember, heavy liquid is an additional surgical tool, so it will increase the cost of surgery for the patient, and also increases another step of injecting heavy liquid, and you have to remove the heavy liquid at the end of the day. So it just prolongs the duration of surgery as well. Direct pressure on the vessel is also something that we do if it bleeds from a big vessel. Another one is when we have to cauterize it. Well, eventually we want to cauterize the bleeder, but the challenge is involved during this cauterization, there will be exchanging of instruments. So the period of instruments exchange will actually cause a fluctuation of intraocular pressure, especially if we don't use a valve trocar. So that will potentially cause more oozing of blood. So furthermore, there will be also a delay from the occurrence of bleeding to the cauterization. So what happens is, frequently by the time we want to cauterize, there will be a pool of blood covering the bleeder site. So then it creates another cycle of rebleeding. Now, previously, before the era of antivegf, before the heavy liquid, I still remember we do encounter cases whereby we just have to abandon the surgery because the bleeding was so profuse and we could not cauterize the vessel, or at the same time, we just can't proceed with the whole surgery. Now, basically, bleeding has been one of the major issues before the era of antivegf. By eliminating the bleeding, we have moved a better surgical outcome. So by simplifying the complex surgery, it is quite common before this that we have to, when it comes to diabetic vitrectomy, we do like 2 hours of surgery. But now it becomes less and less complicated, and it's quite common to finish the surgery within 1 hour or less than that. Let's look at some of the studies. So this study compared the intraoperative difficulty between patients who receive antivegf and those who do not receive the antivegf. What they found was there was significantly less occurrence of bleeding intraoperatively, less incidence of iatrogenic tear, reduced the surgical time significantly, as well as less usage of silicone oil as the endotamponade. Which represent a less complex surgical experience for the surgeon. Now, not only that, there was also less incidence of post-operative vitreous hemorrhage. Now, one of the study looking at the reoperation rate between vitreous hemorrhage and TRD cases with or without antivegf. So this is a retrospective study done in China, having almost 300 eyes. They found in VH cases, those who receive antivegf has lower rate of second unplanned surgery. So 7.7% between those who receive an antivegf compared to those without antivegf is more than double, needs a reoperation. Now, the cause for reoperation is mainly because of post-operative VH or retinal detachment. Whereas in TRD cases, the rate of reoperation was more or less the same between those two groups. Which is the best antivegf for diabetic vitrectomy? So there were a few comparative studies, but looking at a bit more detail, obviously, bevacizumab is almost equally good to ranibizumab to halt the bleeding intraoperatively. But interesting, there's a new study comparing between aflibercept and bevacizumab. So the author reported that aflibercept is far better than bevacizumab. Improvement in terms of surgical time by almost 7 to 8 minutes. And interestingly, the authors also reported less usage of silicone oil as endotamponade, and also a significantly better visual acuity. But again, this is one of the papers that I found recently. I can't find any other paper which has similar results. So hopefully in the future there'll be more and more papers which can come up with more or less the same result, and which may change our practice in the future. But as for now, I think because the improvement of surgical time is just probably less than 10 minutes, and the price of the bevacizumab and ranibizumab is much cheaper compared to aflibercept in our setting, and both are equally good in doing the job of stopping the bleeding. So I suppose that, for me, any types of anti-VEGF would do. Despite knowing all the benefits of antivegf in such cases, it is also worth knowing that antivegf injected before surgery carries a small risk of inducing progression of the disease, or we call it as crunch syndrome. So the main worry is if the TRD progresses to larger area of retina, or we might convert a simple TRD into a TRD-RRD. So most studies concluded that the risk of progression is quite small. 95% are fine. Progression happens in probably about 3 to 5% of cases. And who might progress are those who have a longer duration of diabetes, when they have injection more than 30 days prior to vitrectomy, and those who use higher dosage of anti-VEGF. But for us, we are using 1.25 milligram of bevacizumab, which is very quite a low dose. I mean, that's a standard dose that we always use nowadays. Now, in conclusion, for all advanced diabetic eye diseases, it is important to note that presence of traction, as well as the localizing the traction with the help of BISCAN, if you can't see the fundus, is very, very important. And always warn the patient and try not to delay the surgery after the injection. Now, when do we not need to use the anti-VEGF? Of course, when there's a systemic contraindication. But there's also an ocular factor that, you might not need anti-VEGF in all cases. When you think it's very unlikely for it to bleed, there's no evidence of active bleeding, or maybe if the bleeding occurs because of PVD related, rather than uncontrolled disease. Now, when we have, just to highlight about giving anti-VEGF before surgery, which is also applicable for cataract surgery, just to share the beauty of preoperative anti-VEGF contracting the big juicy vessels anteriorly. This is a case of, I think it's a chronic retinal detachment case, a young patient with the only eye. So, the regression was found as early as 3 to 4 days. Now, briefly on anti-VEGF at the end of the surgery, I think some surgeons do inject anti-VEGF post-surgery, but I think majority will still will choose to inject anti-VEGF before surgery. But if we have to, definitely it helps to reduce post-operative bleeding. And of course, sometimes we do give the anti-VEGF if there is presence of macular edema. Now, in summary, anti-VEGF before surgery is almost a must nowadays in most vitrectomy cases, as it helps to improve the complexity of surgery. So, in return, of course, it will improve the functional outcome of the patient. So, making diabetic vitrectomy less traumatizing to the surgeon as well as to the patient. With that, thank you.